Long-term, structural addiction treatment is a massive commitment. The clinical reality is that many individuals engaging in risky substance use do not require that level of care, and even if they did, many will not accept it. This gap in care is where brief interventions operate. These are short, highly focused clinical conversations, sometimes occurring in just a single session. Their primary objective is efficiency, raising a person's awareness of their behavior and motivating them toward tangible behavioral change. The target demographic for this approach is specific. We are looking at individuals whose substance use is risky or hazardous, but who do not meet the criteria for a severe use disorder. Because of this demographic profile, these tools are most valuable in non-specialty settings. Primary care clinics, in emergency departments, and the criminal justice system are the primary environments for these encounters. Deploying interventions in these specific settings allows clinicians to capture a population that is entirely absent from formal addiction programs. These are people who are not actively seeking treatment. To be effective at a population level, clinical intervention must extend beyond the walls of traditional rehab facilities. It has to intercept risk precisely where it naturally occurs. The most widely utilized and validated framework for executing these intercepts is SBIRT. The acronym stands for Screening, Brief Intervention, and Referral to Treatment. The operational process begins with a quick, validated screening tool. This accurately identifies the client's baseline level of risk, dictating what happens next. Clients identified as low risk receive immediate, objective feedback and positive reinforcement to maintain their current behaviors. For clients identified as moderate risk, the clinician initiates a targeted, brief intervention right then and there to elevate their awareness and build motivation to reduce their use. Then there are clients identified as high risk, or those whose screening indicates a likely severe use disorder. For this group, the brief intervention is paired with a warm handoff, a direct referral to specialized structural treatment. This diagram shows how the SBIRT decision tree routes clinical care. From one single screening input, the logic splits into 3 divergent paths based on severity. This directly operationalizes the core ASAM principle, matching the intensity of the response to the exact level of clinical need. As the flowchart indicates, SBIRT functions as a precision clinical filter. It dramatically extends the reach of care, catching individuals who would never autonomously walk through the doors of a formal program. Once a brief intervention is initiated, the clinician relies on a durable, evidence-based model to ensure the encounter is effective. This is summarized by the acronym FRAMES. F stands for feedback. The clinician delivers concrete data about the client's personal risk or impairment respectfully, utilizing the exact information the client provided during the screening. R is for responsibility. The burden and autonomy for change are placed explicitly with the client. It is entirely up to them what they do with the information. A is for advice. The clinician offers clear, professional recommendations for behavioral change, but does so without applying any coercion. M is for menu. By providing a menu of behavioral options, the clinician allows the client to choose a path that actually fits their life and preferences. E is for empathy. Throughout this brief encounter, the clinician maintains a deeply compassionate, leveling relational stance. Finally, S is for self-efficacy. The clinician actively builds the client's confidence by affirming their personal capacity and reminding them of previous life successes. If these steps sound familiar, it is because the FRAMES protocol maps directly onto the methodology of motivational interviewing. A brief intervention utilizing FRAMES is, at its core, motivational interviewing delivered in a highly compressed, efficient format. The protocol provides the structural rigidity necessary to make a 10-minute interaction effective, without sacrificing the relational warmth and respect that ground all counseling. Beyond these single-session encounters, there is a broader category of interventions known as brief therapies. These are highly focused treatments, strategically delivered over a small, strict number of sessions. Solution-focused brief therapy, for example, bypasses deep historical exploration. Instead, it concentrates entirely on client strengths, times when the problem was absent, and visualizing a preferred future. Brief cognitive behavioral protocols deliver targeted, compressed skills training, helping clients identify and alter destructive thought patterns in a short time frame. Motivational Enhancement Therapy, or MET, operates as a structured, rigorously time-limited application of motivational interviewing. MET relies on personalized assessment feedback, systematically presenting the client with data about their substance use to strengthen internal motivation for change. These brief protocols are not lesser forms of treatment compared to long-term care. They are deliberate, exact matches of intensity to need. This brings us back to the foundational axiom of clinical judgment. Treatment intensity must precisely match the client's actual need. Consider a client presenting with risky use, but lacking a severe disorder. Placed in a long-term residential program, they would be misplaced. They benefit most from a brief intervention. Conversely, a client presenting with a severe disorder who is operating within a highly unstable home environment strictly mandates comprehensive structural treatment. Over-treating a mild case wastes vital systemic resources and often generates immense frustration for the client, potentially driving them away from care entirely. Under-treating a severe case carries extreme risks. Providing only a brief intervention to someone requiring inpatient care inevitably sets that client up for clinical failure. The initial screening skills, the ASAM placement frameworks, and these brief intervention tools all operate synergistically to execute this exact matching task. Precision in risk matching prevents systemic waste. More importantly, ensuring the patient gets exactly the level of care they need is the defining characteristic of ethical clinical practice. Even in the shortest interventions, the compressed nature of individual counseling inevitably magnifies interpersonal dynamics. The relationship itself becomes a clinical tool. Navigating this requires the counselor to maintain strict professional boundaries. They must actively manage transference and countertransference, relying on self-awareness and professional supervision to keep the dynamic healthy. There is an ethical imperative here. The clinical focus must remain strictly tethered to the client's goals. The counselor's personal or emotional needs are excluded entirely from the room. Still, relational sticking points are a reality in therapy. Clinicians routinely encounter missed sessions, intense client guardedness, or outright conflict. When an alliance rupture occurs, the clinician must address it directly. They utilize the specific microskill of immediacy, naming exactly what is happening in the present dynamic to initiate repair. There is a counterintuitive truth to this process. Well-handled alliance ruptures frequently result in a significant deepening of the therapeutic work. No screening matrix or clinical framework can succeed without constant, rigorous attention to the client's autonomy, their cultural context, and the profound human meaning embedded in the helping relationship. Whether the encounter was a 10-minute brief intervention or an hour-long therapy session, it concludes with a mandatory administrative step: formalized documentation. A clinical record requires specific data points. The counselor must record the session's focus, the client's participation level, and any measurable progress made toward formal treatment objectives. The record must also capture any clinically significant content that emerged and clearly delineate the concrete plan going forward. The standards for this recording are non-negotiable. The documentation must remain entirely accurate, rigorously objective, and strictly confidential. High-quality documentation functions as an anchor. It takes these individual, highly concentrated sessions and ties them back into a single, coherent treatment plan. This administrative rigor actively supports the continuity of care. It ensures that critical information is preserved across different providers and varying levels of the healthcare system. Thorough documentation serves as the ultimate clinical safeguard. It protects the integrity of the ongoing therapeutic process. It ensures the safety of the client, and it secures the professional liability of the counselor.